Before putting sterile gloves on, position the patient. Sit up facing the fetal heart rate monitor, making sure they're not sitting on the split in the mattress. Tie down around neck and flip over shoulders. Slide monitoring belt securely under buttocks. Identify and mark the right iliac crest to make a reference line for L4. Imagine a line crossing to the left iliac crest. This line crosses the L4 interspace. Do not feel interspaces at this time. Put on sterile gloves and place epidural using the following technique. Prep the back using the chlorhexidine applicator, extending prep area 3 to 4 levels above and below intended level of needle insertion. Apply clear plastic drape to patient's back. Place hole in drape so it is centered on spine with bottom of cutout 1/3 below L4 and 2/3 above L4. This should leave approximately L1 to L5 exposed. While the prep is drying, at least 30 to 60 seconds, take time to prepare your kit. In the 3 cc syringe, draw up 1% lidocaine for localization. In your 10 cc syringe, draw up sterile saline. Lay paper drape on bed and position off to side but overlapping plastic drape to maintain sterility. Uncap and pick up local anesthetic syringe in dominant hand and reposition the patient if necessary. Using non-dominant hand, identify desired interspace. Start high and work your way down the spine until you feel the best space, frequently L2 to L3. As soon as you identify the appropriate interspace, inject local. Raise a superficial dime-sized skin wheel, making the skin look like an orange peel, and inject deeper to confirm you are in the interspace. Immediately sheath needle when done injecting local. To sheath, lay needle cap in tray in such way that allows the needle to be slid into cap without having to hold the cap. Do not leave infiltration needle in the kit uncapped. Again, reposition the patient if necessary, and with epidural needle in dominant hand, use non-dominant hand to re-identify interspace. Pop the needle through the skin and then slowly advance until needle seats firmly into interspinous ligament, approximately 3 centimeters. Once seated, let go of the needle when reaching for glass syringe. You don't want to be holding the needle if the patient moves and your attention is focused on the glass syringe. Connect the glass syringe to needle with plunger pulled back to 3 to 4 mils. When connecting glass syringe, always stabilize needle first by placing knuckles of the last 3 fingers against patient's back and hold the hub of the needle with thumb and index finger, then connect syringe. To find epidural space, use intermittent advancement technique with loss of resistance to air. Check for loss of resistance before advancing the needle, and advance the needle in 1/10 of centimeter increments. Alternately push on plunger with thumb without removing thumb from plunger. When you push on the plunger and it does not come back but instead gives, you have found the change in resistance, often described as a loss in resistance. This indicates that you have found the epidural space. Remove the glass syringe and attach saline syringe using the above stabilizing maneuver, and inject a few cc's of saline. This confirms epidural space and dilates the space. While maintaining control of the catheter, thread catheter 5 to 6 centimeters into space. Make note of where you lost resistance on your TUI needle, and carefully withdraw needle from skin while stabilizing catheter. Then pull catheter back to appropriate position, leaving approximately 4 centimeters in space. Draw up your test dose in the 5 cc syringe. 3 cc's of 1.5% lidocaine with epi. You do not need to label the syringe if you immediately administer after drawing up. With the patient still sitting and after negative aspiration, administer test dose. You may then tape the catheter while waiting for test dose results. Tape the catheter up the patient's shoulder on whatever side the epidural pump is located. Once a negative test dose is confirmed, you may begin to plan for your loading dose.